How likely is it that cancer will return? What symptoms and signs might there be if you have a potential recurrence? And what can be done to lower the risk of cancer coming back after treatment? Hello and welcome. I'm your host, Dr. Musamtomeni. Signing with us today is Pumza Skumba. National Cancer Survivors Day is an annual treasured celebration of life that is held in hundreds of communities nationwide and around the world on the 5th of June. It is a celebration for those who have survived, an inspiration for those that are recently diagnosed, a gathering of support for families, and an outreach to the community. On National Cancer Survivors Day, people around the world will unite to recognize cancer survivors, raise awareness of the ongoing challenges for cancer survivors, as well as, most importantly, celebrate life. On Vital Science, we'll focus on cancer survivors today. Coming up on the program, producer Nompilo Kwala spoke to a young man that was diagnosed with a muscle cancer. We also spoke to a breast as well as a prostate cancer survivor about their journeys to becoming cancer survivors. We'll speak to the head of oncology at Wits University about life after cancer treatment, and then we'll speak to the head of the Helen Joseph Hospital's breast care clinic about the importance of quality cancer care and, of course, effective health services for early diagnosis and treatment of cancer. We'll then speak to the Assistant Director of Women's Health from the National Department of Health about cancer care in the public sector. Remember that you can be part of the show by asking the guests that we'll have on the questions that you have on your mind by simply sharing your view with what and on what we're discussing. The number to call is 011-714-5861 or 011-714-5877. Also social media on Twitter, it is at SABC Vital Science, or Facebook. You can also share your thoughts with us there. It's SABC Vital Science. We continue with the show right after this ad break. Welcome back to Vital Science. I'm Dr. Musamtomeni. In South Africa, 1 out of 4 people will be affected by cancer in their lifetime, and the number is growing every year. Now, early detection is key to enabling effective treatment and a better chance of recovering from cancer. Producer Nompilo Kwala spoke to a representative from the Childhood Cancer Foundation South Africa, Terence Seegers, and to Chavo Mahanga, a muscle cancer survivor, and he shares his journey with us.
National Cancer Survivors Day is a day commemorated to spread awareness and information about cancer and to honor the survivors of the deadly disease. The day gives cancer survivors hope that life after diagnosis can be full and fruitful too.
I was diagnosed with cancer of muscles in 2020 June, which is rhabdomyosarcoma. I went to Baragwanath Hospital at hematology, whereby they after a numerous biopsies and operations, is whereby they tell me that I have cancer of muscles. I find this after while my mother passed away in 2018. So in that moment I was alone, and there was no one who can just to say no, everything will be fine. I was alone in that moment. The most difficult of my journey, it was the time whereby I started to take chemo, and the time where I started to be admitted at Baragwanath Hospital. As I'm a child-headed household, I'm the one who is older to the family, whereby I stay with my 2 siblings. It was hard for me to leave my siblings alone at home, because there was no one who was going to take care of them. I was the only one who would take care of them after a while my mother passed away.
People with cancer may feel stressed and overwhelmed. It is normal for them to have mixed emotions. That is why it is important for them to have network support such as Childhood Cancer Foundation.
In that moment where I was diagnosed, I felt that I was the only one who have cancer, but unfortunately, as I went to CHOC, there were many children with cancer there. Childhood with Cancer Foundation helped me by providing accommodation for me as I was going to Joburg Gen Hospital, which is Charlotte Maxeke. I didn't have money for transport. It's whereby they provided me with accommodation whereby it is at Deep Kloof, which is nearby hospital. And they also gave me emotional support at that moment whereby I was not even feeling well. They also provided me with a food parcel whereby I have to feed my siblings with that food parcel.
The Chalks Foundation Communication Coordinator, Taryn Seegers, said that the foundation provides free, comprehensive support to families of children with cancer and life-threatening blood disorders.
Any child diagnosed with cancer has access to treatments and the support that they need, which goes hand in hand together. And we just basically provide all of that support to the families as well as the children or the teenagers to make sure that they are as comfortable and the treatment process is as easy as what it can be. Something that we're really trying to push and drive at the moment is the early warning signs. So the earlier a child is diagnosed with cancer, the better chance of the survival. So if they know the warning signs to look out for, they're able to identify these signs.
Statistics have shown that in South Africa, an average of 800 to 1,000 children are newly diagnosed with cancer annually, and that at least half of all the children with cancer in South Africa are never diagnosed.
So it's a very scary statistic. With the World Health Organization, it was estimated 1 in every 400,000 children would come into contact with cancer. And the most common ones are your leukemias, which is cancer of the blood, as well as brain cancer and lymphomas.
After the break, we'll speak to Dr. Georgia Demetria, the head of oncology at Wits University, about life after cancer treatment. Stay with us. Welcome back to Vital Signs. Today we're talking about cancer and, of course, the surviving of cancer. South African men have a lifetime risk of 1 in 7 to get a cancer, while women have a lifetime risk of 1 in 8 to get cancer. Now, producer Nompilo Kwala spoke to Lucas David, a prostate cancer survivor, and Cindy van Wyk, a breast cancer survivor, about their journeys to becoming cancer survivors.
According to the National Cancer Registry, 1 in 26 women are at risk of developing breast cancer, and 16% of cancer deaths are attributed to it. We speak to Cindy van Wyk, a breast cancer survivor, about her health journey.
I was diagnosed in August 2014. It was a month away from my 47th birthday. I'd just come back from living in the US for some time. I'd taken a bit of a corporate sabbatical, and I'd come back from an absolute high, and I picked up a lump. It was a routine mammogram, and when the mammographer did the mammogram, I could see the concern in her eyes, because it wasn't just a small lump, it was actually quite a big lump that was protruding on the outside of the breast. So I sat there and I thought, this can't be happening. It's a very surreal experience.
Most cancer patients say chemotherapy is the hardest for them. However, for Cindy, breaking the news about her diagnosis was the most challenging.
I think the most difficult is once you've had the diagnosis, and before they even discuss the treatment protocol with you, is that time between receiving the diagnosis and seeing the next part of the medical team in the journey. Is the first step there is processing the information that you've just received. And the most difficult thing there is, before we even get into the medical protocol, is now starting to tell people. The cancer was only on the one side, but I elected to have both breasts removed because I just know myself that I couldn't go through a rigorous treatment regime and have a mastectomy on the one side and then still go for regular checkups. And I just said to her, please remove both.
Prostate cancer is the #1 cancer affecting all South African men, with 1 in 17 men being at risk for diagnosis in their lifetime. David Lucas, a prostate cancer survivor, shares how early detection saved his life.
In 2011, I complained of my finger joints. And my finger joints were sore. And I said to my doctor, he's a friend of mine. And I said to him, listen, I think I've got rheumatoid arthritis. And please, you must send me to a rheumatoid specialist. A couple of days later, he phoned me. He said to me, David, my dear friend, you don't have arthritis. You have gout. But, a big but, your PSA, which is the prostate-specific antigens, are raised. Now that is a marker for prostate cancer.
It is important for adults to have their annual checkups because early detection and treatment will not only give one better quality of life, but also possibility of a longer life.
It's a scenario where if it is caught early enough, particularly prostate cancer, has got a success rate of virtually 95% cure. The moral of the story is early detection.
The South African cancer survival rate is 6 out of 10. Doctors use a 5-year lifetime or time frame when they refer to survival. Now, if the cancer did not recur in those 5 years following either diagnosis or the treatment, patients are considered to have become survivors. Now, we're speaking to the head of oncology at Wits University, Dr. Georgia Demetrio, about the cancer survivors and all the treatment that they have to go into. Good day, Prof. Thank you so much for joining us.
Good morning. Thank you for having me.
So let's speak about this idea of a diagnosis. A lot of people find themselves in positions where they get a diagnosis of cancer. But what goes into getting to a diagnosis? What are the most common issues or presentations that you find with the people that come to your oncology clinics?
So the most common cancer we see is breast cancer. So certainly for women over the age of 40, we would advocate for self-examination of the breast. And obviously, if you feel any lumps or bumps even before that age, definitely present to your healthcare provider or professional, be it a primary healthcare clinic or be it, in fact, your GP, and let them assess you. Mammograms often are, as a regular screening method after the age of 40, a way for us to pick up really small cancers before they are actually palpable. And as some of your speakers have said, we want to pick it up before it's potentially palpable. The earlier the pickup, the better we're going to be able to treat our patients. Also, colon cancer is quite a big sort of presenter in the country. And we need to advise people if you've got a change in your bowel habits, if there's any bleeding when you go to the toilet, please, please, please do present to your doctor, advise them of any kind of symptoms. Anything that just isn't quite right with your body that you feel, please go and just advise your healthcare professional. Prostate cancer, annual screening, also very important. So trying to just be aware of what is normal for you and what has maybe changed is something to be aware of. Lymphomas, feeling lymph nodes that are enlarged, lumps and bumps, wherever they may be. Also, go and see a healthcare professional. Once we think that there's malignancy or a cancer, we would then expect a biopsy or need a biopsy to make the definitive diagnosis. And that then allows us to confirm, yes, it's a cancer. Once we've confirmed a cancer, we would always need to stage it. So X-rays, imaging, CT scans, sometimes even PET scans need to be done. And then we can map a plan. Sometimes we start with surgery. Sometimes we start with chemotherapy. And sometimes the patient needs combination chemo with radiation therapy. So there's various treatment options for various different cancers. But having the full picture, the histology, the scanning and the staging allows us to make the best treatment plan.
What do the numbers generally look like with respect to people that have received a diagnosis, start to get the treatment, and I guess make it out or find themselves in a position where they don't or no longer have a cancer?
So it depends on the stage of pickup in terms of how many patients we are able to get to the point of survivorship and being survivors. So, for early stage breast cancer, there's a 95% plus 5-year survival rate. Obviously, if it presents very late, once it's already spread, then we're dealing with a very different scenario and unfortunately the stats are not as good. So that's why we keep going on about early detection, because the stats definitely improve in terms of 5-year survival for a stage 1 presentation versus a stage 4 presentation.
So how long will it take for a survivor to get better or feel better after they've gone through the initial treatment?
So sometimes we always say there's going to be a new normal. Many of the treatments we use create difficulties that might last indefinitely and sometimes permanently. But we try to minimize those as far as possible. But in terms of the weakness, the tiredness, post-chemotherapy or radiation treatment, there's really at least a 3-month period after the treatment completes before patients start to feel their energy levels improving, that they are able to basically get back to almost a normal way of living life.
So what kind of after-treatment care would one need to start putting in place in order to get back to what would be a normal life or start feeling better again, even after that 3-month period of either you having radiotherapy or chemo or treatment along those lines?
So I think the most important thing is just to speak to our patients, always find out emotionally where they're at, are they coping? Because often during the actual treatment phase, patients are just focused on fighting and getting themselves through treatment. And once the active treatment part finishes, it's almost like a post-traumatic stress disorder where sort of suddenly it dawns on them what they've gone through and how the magnitude of the diagnosis has impacted them. So psychological care in terms of being able to speak to someone, support groups or a psychologist, always very important to put in place. And then also just to be able to have a good balanced diet. Exercise often does help patients recover a lot of their strength in moderation to slowly increase the amount of exercise. Well-balanced diet, we always say more greens, more vegetables, more fruit, reducing saturated fat intake, reducing refined sugar intake, and keeping alcohol to a minimum are all things to put in place to just improve recovery.
Now, different people may have a similar cancer but have different outcomes with respect to whether they survive or not. What factors contribute to someone not surviving or, more positively, someone surviving a cancer?
So, the stage of presentation is probably the one that has the biggest impact on ultimate outcome. But some cancers, even though they are the same stage, the biology of the tumor can be very different. You can have a very aggressive tumor, which is a very high proliferation index, so it's dividing very fast, and that's more aggressive, and a lower grade tumor that's very slow in its division, and those cancers tend to have better outcomes if they are slower dividing and low grade. So it's biology, it's stage, and certainly nutritional support does play a role, as well as a patient being able to attend for their visits and be able to be compliant. Financial constraints are often a huge challenge for our patients.
As some of the reasons, and I think you've just started to mention a few now, what other factors, socioeconomic and such, contribute to people not necessarily reaching a point of survival that are outside of just the biology of the cancers and the possible treatments that we do find?
So, also I think where patients live has a huge impact in terms of distance that they have to travel to access care. Sometimes the initial presenting, then having a mammogram for a breast cancer patient, say, then having a biopsy, then having staging scans, all of those require the patient to represent before they even have started their treatment. So if someone stays very far from an oncology unit, that obviously does stack the odds against them. That brings in travel costs as well. So that is the one issue. I think also a lot of fear and anxiety around the word cancer. A lot of patients are very, hesitant to be able to sort of say, well, this is definitely what I have. We need to counsel patients.
Hello, Prof.
Hi, yes, can you hear me?
Yes, yes, we can hear you now. We lost you there for a second, but I think you highlighted important bits in that, you know, the further you are from a center that does do oncology and does treatments and things such as that, obviously that affects whether or not, you know, you reach that point where you get to a 5 years. But what does life look like for someone post the 5 years? So they've had the cancer, they had the treatment, they've followed up in the 5 years to see if there is any recurrence of the cancer, but now you reach this 5-year mark. What does life look like, and what does life look like post that?
So definitely the one thing we need to do is get our patients to come and see us on a regular basis. So from that, we need to just be sure that our patients have got regular follow-up appointments. The next thing we need to always do as well is advise our patients what screening investigations they need to have. So, you know, if you've had breast cancer, you still go once a year for a sonine mammogram. If you've had a colon cancer, usually every 3 to 5 years, you have a colonoscopy. For prostate patients, we check bloods on a 3 to 6 monthly basis to be sure that the prostate-specific antigen, or PSA, is not climbing. So all of those things we put in place. For the first 2 years, we say to patients, maybe see us every 3 months often. And after the 2-year mark, we start to say, okay, let's see you every 6 months, check bloods, check on medication if they are on maintenance treatment, just as a hormonal blockade or something, and just to optimize follow-up and just keep checking in that they're not having any symptoms which might suggest a recurrence.
Now, the big thing with patients that do have cancer is that 5-year mark. And of course, the percentages that highlight whether or not survival is positive or negative with respect to that. But a lot of patients will find themselves reaching a 5-year mark and then declaring themselves to be cancer-free and then living the rest of their lives thereafter. Is this advised? Will the cancer ever come back?
So we do see late recurrences in some cancers. Breast cancer, sometimes we can see recurrences 10 and 15 and 20 years down the line. So yes, if a patient hits 5 years, we can say, well, you're in remission. That's 5 years disease-free with no evidence of disease recurrence. But that doesn't mean that you stop doing a regular follow-up. I think that's maybe where the misconception arises, because the annual mammograms, the colonoscopies, the PSA checks, all of that actually needs to continue. You might do it a little bit less frequently, but we always advise patients that not only can a cancer recur post 5 years, but sometimes a second cancer can even arise. So staying in touch with your healthcare professional, seeing them on a less frequent yet regular basis also improves the chances of survival. Because again, if a second cancer recurs or occurs, then definitely we know that picking it up again sooner rather than later improves the chances of dealing with that successfully as well.
And lastly, Prof, the idea of long-term effects, either of the treatment or just the initial insult of having the cancer. Are there any big ones that we need to be aware of? And what are some of the signs and symptoms that people need to be aware of if they think their cancer is recurring?
So, if someone's developing bone pain, we always worry, has something gone to the bones? So if you're having a pain that's gnawing and not going away, please represent. If you feel a new lump or a bump, please represent. If there's anything that you're just not feeling quite yourself, or what is your new normal, please then represent. So I think new lumps, new bumps, bone pain, any fatigue or loss of weight as well, that you can't explain. You're not on a diet, but the weight is just falling off. Please be concerned about there being a recurrence, and at least see your doctor to check that there isn't anything concerning.
Well, Prof, thank you so much for joining us this morning and really going out to discuss what life after a diagnosis, but importantly, life after treatment with cancer actually looks like. That was Dr. Georgia Dimitriou, the head of oncology at Wits University. After the break, we'll speak to Professor Carol Ann Ben, the head of Helen Joseph Hospital's Breast Clinic, about the importance of quality cancer care and effective health services for early diagnosis and treatment of cancer. Remember that you can be part of the show by asking the guests that we have any questions that you have on your mind. Simply share your views with us about what we're discussing. The number to call is 011-714-5861 or 011-714-5877, or social media at SABC Vital Signs. And it really is that simple. We'll see you after this ad break. Welcome back to Vital Signs. Namhlanje sikhuluma ngabantu abasurvive i-cancer. If wena ukhona umuntu omaziyo noma wena self wazibona usurvive i-cancer, then ungathola uthuba ukuthi usifonele usho ukuthi impilo yakho yaba njani ngaleso sikhathi. Kodwa ke sisakhuluma nabantu ke abazaziyo lezinto kakhulu and sikhuluma ngoproblem ke manje. Kodwa ke many types of cancers can be detected at an early stage when they have just started and of course are yet to spread to other parts of the body. Now, a lump or thickening on the skin can be a late sign or an early sign rather of you having some sort of cancer. We're joined by the head of Helen Joseph Hospital's breast clinic, Prof. Carol and Ben, to talk to us about the importance of quality cancer care and effective health services for early diagnosis and treatment of these cancers. Welcome, Prof. Thank you for joining us again.
Always good to be here.
Lovely. So let's speak and talk around this idea of cancer and why it's so important to have early detection.
So I liked what Prof. Demetrius said. You've got to know your norm. If you know your body, then you know what to look for. So you mentioned early that lumps and bumps and thickenings can be early or late signs. Really, it can be either. So if you know your norm and you check every month, and I just want to reiterate, flat hand, not this hand above, because then you can't feel, you know, when you do sonars, you lift the arm up, that's where we get it from. But if you relax down, you can feel things nicely. So early access to care means that we need to have open access clinics. That's what we do, as you well know, at the Helen Joseph Breast Clinic. You have a concern, you come in. Breast pain is most likely not breast cancer, but lumps and clear nipple discharges can be. However, if you have a continual bone pain or something in a leg that is, and cancer pain doesn't go away. So it's that constant pain that doesn't get better. Like Georgia mentioned, loss of weight, you are battling shortness of breath, you're battling to eat, esophageal cancers. So we want open access clinics. We want people to be able to come in and get screened effectively. So what we set up, and I think you were well part of it, was this color-coded radiology concept. If it's suspect for cancer, you code it as a red, like a trauma triage, a yellow if you're worried there's something there, and a green if you're just trying to get someone into a screening, be it cervical, be it breast, be it something else. And this is important. We need to make health care easy for people to access because it's often not awareness. You know if you've got a headache, if you've got a lump, if you've got a stone in your shoe. So people are not ignorant. They need to be aware of how to access into services in a cost-effective way. So you don't land up with a private mammogram, an ultrasound, and a call costing 20,000 Rand if you're not on a medical aid. You need to know where to go and where to turn so you don't land up with those problems.
So what are some of the initial things, apart from knowing your body, that people should do, apart from accessing the health services as well, people should do in order to, you know, have that red flag that says that, you know, potentially something's happening
So know your family history history on your father and your mother's side, and we're looking for cancers at an early age. So if you've got significant, and it's not just maternal, so male prostate translates to a high incidence of breast cancer in women. Know your family history of other cancers. Remember, cervical is not related to breast. We confuse the two. Ovarian is. Understand stomach, colon, pancreas. So you want to understand what's going on in your family. You can choose your friends, but not your family. Otherwise, 65% of people who get cancers have no risk factors. So what are you going to look for? You're going to see if you have any unusual looking moles, if you've got any shortness of breath, head and neck lumps, breast lumps. Men, remember the prostate is hidden. It's a bit like the cervix. They present late symptomatology. And I often think we are not so aware, our men are not as aware as our women, because if you look at the incidence of prostate in men, and particularly South African men, being picked up at an earlier age.
So this idea that goes around diagnosis is an interesting one because we always try to get patients in as much as we can, but at the same time facilities become slightly obstructive with getting people in. So, you know, if you have a small little mole and you present to a clinic, someone will somewhat laugh you off because, I mean, honestly, you've got to be joking. So who's responsible for early diagnosis, or not even diagnosis, early just assessments?
I think you must take responsibility for your own health, and we've got to push healthcare systems to provide good care. So similar to the mole story, you have a 25-year-old who presents with a breast lump and everyone goes, you're too young, it's a fibroadenoma. But you and I well know it could be a triple negative breast cancer. So you need to be able to say, I'm not happy And how are you proving to me that this is something that I need to not worry about or worry about? And that is not about pushing unnecessary surgery. The radiologist is the gatekeeper, and the pathologist with a core biopsy or biopsy, many different types. I think there's not many parts of the body that the radiologist can't, from an interventional point of view, access, give us a tissue diagnosis so we can work out the behavior of the cancer. So the behavior of the cancer, the organ it arrives, and then we stage it, and then we plan a personalized treatment regime.
Right, so we've got a caller on the line. Class, good morning. Hi, yes, we're listening. What's your question?
No, you see, I've been for a checkup 2 years back.
Okay.
You know, it's for this checkup for cancer for men, you understand?
Okay.
So I went through the treatment. I think everything went well. But now just see appearing again on TV just struck me that I'm 2 years late. I wanted to know what are my chances. Can I go back to the clinic or what should I do?
All right, thank you for that question, Klaus. Right, so I think Klaus speaks to an important thing, and this is the issue of defaulting, as well as, getting a diagnosis and then stuff happens in between, as many people experience life, and then wanting to go back to the clinic. So let's speak around patients and the defaulting of services.
So I think that the first thing is, from a medical point of view, no judgment, okay? People choose one route and then change and choose another route for a variety of reasons, okay? And we will always accept people with open arms back in the system. So if you haven't been for a checkup for 2 years, for whatever reason, okay, come in. We will work out from our breast clinic point of view what tests you need and where to go. So here we've got a gentleman from a prostate point of view. What I'm going to say to him is, if he sneaks his nose past the breast clinic tomorrow, I'll head him in the direction of the urology clinic at Helen Joseph. But that's the point. The point is, we all choose different roads. I always say a cancer journey is a road, and we go in different directions at different times. It's no different to the road we live in our life every day, You're going to choose times where you're going to go one route and then another. So don't be upset if you were given a cancer diagnosis and was like, I didn't want to go for chemotherapy. And I want to just shout out to Prof. Demetrio, who has revolutionized the oncology service. For me to refer in at Charlotte, which is where oncology is, it's less than a week backlog on anything.
Sure.
So that is a really good thing. So you can get your treatment. So if you said you weren't called, or you went and tried an alternative, which I actually don't like, I like the term complementary, come back in, because we will reassess and retry and see what we can do. It's never too late.
Prof, let's speak around the psychology of getting a diagnosis of cancer. I think it's such an important thing that highlights the behaviors and the road then that people end up taking. What goes on in the mind of someone that's received a cancer diagnosis?
So I liked listening to your speaker earlier to say it wasn't so much the chemotherapy, it was the shock of the diagnosis. And I write extensively, and I talk about something like Alice in Wonderland, down the rabbit hole. You literally feel like you've landed in a different world. People are talking different things. It's like gobbledygook, do this, do that, etc. And who do you listen to? So I have another article, and you guys are welcome to load them up and translate, etc., called Ghostbusting. You want your team of Ghostbusters, family and friends, who are going to give you sensible advice. Don't rush in. Go for second opinions. It's your body. You don't need to take your breast off. And then you want your medical ghostbusting and a navigation team, because each people or person digests information at a different pace or rate, and different responses. So I was lecturing in Egypt this weekend. The concept of losing hair around a cancer diagnosis is a big thing for people, and you need to, if you deal with things correctly, here's how you can dress. Here's what we can do. Yes, it will grow back. If it's an open communication and it's a horizontal, not a vertical medicine, you're more likely to get people opportunity to understand the diagnosis, digest it. It's not like being thrown off a bungee jump. It's not Little Shop of Horrors, round your body in 2 days. It's a concept of, let's take a week or two, work out a treatment plan for you. Are you happy? Do we want other opinions? And And I think if people are held in a multidisciplinary environment, particularly by navigators who've been through it, who speak the same language and the same culture, I'm always acutely embarrassed by my lack of extensive African languages. So now I'm counseling a Gogo. For her to speak to Omar or Jeanette, who speaks all 11 languages, after me, is far more important than anything I've said. Okay.
It's quite interesting. Quite interesting. Look, we're running a consult clinic, it seems, today, because we've got another caller on the line. Pumelo, thank you for your call. What is your question?
My question is, I've just put an implant, so I've got a terrible pain in my stomach cramps, and then I've got a small child at 10 months old, and then yesterday I was at the clinic since I've got complications because I've put an implant. So I'm scared now because I'm listening to what the doctor's saying now. That pain, can that cause cancer for me, or this a complication of implant?
All right, thank you for that question.
I'm trying to work out where her implant is, whether it's
I'm assuming it's the contraceptive implant.
Or a contraceptive
That's
implant.
my assumption.
Okay.
Yeah.
So a contraceptive implant's not going to cause stomach pain. Okay. And thank you so much for calling in, because I always say I know lots about breasts and nothing about any other aspect of medicine. but it's often a fear is we don't know if we've got one thing, how it's going to affect something else. So no, it's not related, and you need to have somebody give you the, not just oh, well, it should go away, but what is the next step? If you've got pain for a day or two and cramps and you have some diarrhea and vomiting, okay. But if you have pain continually, have they soned your liver, check that you've got gallstones, do you need a scope? Have you been taking pain medicine and now you've got an ulcer? And then it becomes a vicious circle.
Yeah.
So that's why I love programs like this. You're in such a powerful position for people to access useful information around medicine so they can take primary responsibility for their health and push for good service.
Taking primary responsibility for your health and pushing for better services. That's what Prof. Ben has said this morning. Thank you so much for joining us and really highlighting the importance of early detection, knowing your body, knowing what's normal, and going out to seek the help, because you will be your own advocate with respect to your health. That was Professor Carol Ann Ben, the head of Helen Joseph Hospital's breast clinic. After the break, we'll speak to Dimpho Chonyakaya, the Assistant Director of Women's Health from the National Department of Health, about cancer care in the public sector. Stay with us. Welcome back to Vital Signs. Today we're talking about cancer survival. Now, the COVID-19 pandemic has resulted in thousands of patients waiting to have their surgeries for cataracts, for breast, as well as prostate cancer, and of course with some implants too. Now, some patients have been on a waiting list for more than 2 years. With COVID-19 pandemic in South Africa, of course, interrupting oncological services in private as well as the public sector, we explore surgical catch-up plans and ask the right questions with respect to what's being done to address the underlying problem of these backlogs. We're joined by Assistant Director of Women's Health from the National Department of Health, Mam Dimpho Chonyakaya, about the cancer care in the public sector. Good morning, Ma. Thank you so much for joining us.
Manisa, thank you for having me.
Good. So let's speak around what this idea of a backlog is. What does it mean when the Department of Health nationally says there are backlogs with respect to surgeries, to oncological services? What does that mean?
Okay, basically a backlog is a situation whereby the patients have been diagnosed. And obviously, after the patients have been diagnosed, the expectation is that they are put on treatment, either surgery, radiation, or chemotherapy, or a combination of the 2 or 3. And essentially, because of lack of access in certain areas, it is difficult for them to actually be put on treatment on time. On time, we talk about at least 6 months after diagnosis, somebody must have been on treatment. So basically, because of the backlog, because of the lack of resources, human and material resources, and lack of already set up services around different provinces, because provinces are different in terms of their services available. It becomes a problem for them to actually reach treatment, to be accessing treatment on time. And part of that would be, as we know, a lot of provinces did not actually have a well-coordinated cancer services, oncology services in the past. So they were more dependent on cross-border services. And part of the cross-borders were not actually having the memorandum of understanding. So the patient would actually use the opportunity for themselves to access treatment in one way or the other, just maybe getting somebody's address to be able to access treatment in Gauteng while they're in Northwest or they're in Free State or wherever.
Now, naturally, this, of course, creates a lot of problems with respect to overloading certain systems. So if you are a Charlotte Maxeke, for instance, in Johannesburg, and you do oncology there, and you're having to see patients from Limpopo, from Northwest, from Mpumalanga, it creates a problem. But it is no fault to the patient themselves, because all they want is treatment regardless. So how are we addressing these backlogs specifically, and also increasing access to oncological services and things such as that for these patients in their own provinces?
Oh, definitely. It is not the patient's problem. It is a systemic problem. So, but systems have been put in place to ensure that different provinces do have establishment of oncology services. As we talk since the time of the development of new policy that is actually mandating the Department of Health to ensure that there is proper access to oncology services. Most of the provinces actually started off with their oncology services, though they are still at infancy level. I would give an example of the Northern Cape, where they have established a unit in the Appington area. I would talk about Mpumalanga, where the facility has been established in Rob Ferreira in Nelspruit, to ensure that, because most of the patients from Mpumalanga and Limpopo were dependent on Gauteng. So that will actually curb the problem with backlog.
So
just to mention few.
So issues of backlog also live in and around not just access, but having actual facilities to use those services. So having chemo drugs, having radiation services on site. Are these services back up and running, for instance, in Gauteng, which was a major hub for assisting people with these cancers in terms of diagnosis as well as treatment?
I think part of the issues that actually make Gauteng not to be doing quite well in terms of the backlog management is bulk of the patients are coming from different provinces flocking into Gauteng. And of course, Gauteng is doing much better as compared to other provinces because of easy access to facilities, because of availability of human resource, availability of material resource as compared to other provinces. And for that reason, Gauteng has actually even assisted other provinces, like you talk about KZN, where there was a backlog in KZN, where the VETS consortium actually went through to assist in that province. So they are really doing much better as compared to other people. And obviously with the drugs and all that, obviously if your system is becoming overloaded from somebody that you haven't budgeted for, you are going to definitely have a problem, like Gauteng is, because of the cross-border issues, Northwest, Limpopo, and Free State and all that. And Mpumalanga that are actually using the resources that were not budgeted for in Gauteng.
So how are we addressing those issues? Because it's one of those problems that feed themselves each and every time. So if I'm sitting in the Free State, I've received a breast cancer diagnosis, and there are no services in the Free State, naturally I'm going to catch a taxi to Gauteng, get an address from my cousin who stays in Soweto so that I can access services. But if that problem isn't being fixed, more and more people are going to keep coming to Gauteng because it is now recognized as a center where people can at least receive treatment.
I think, like I've alluded earlier to say, provinces are now doing something about it, establishing oncology services units, because it is mandated from the cancer policy of South Africa that the regional breast units must be established. Regional oncology services must be established per province, and it depends on how much of that they want in their province. It can be 2, it can be 3. So basically, as it is, there has been strides in the right direction, whereby some provinces have already established some units whereby they are keeping the issue of patient having to wait longer to access something like your chemotherapy.
Okay.
That's being addressed.
So let's speak about the backlog and what the numbers actually currently look like. I know different provinces have got different numbers, but let's take Gauteng, for instance, with respect to how long people would wait for basic oncology services, and then other provinces I know where KZN was having issues with oncology as well. So what do those numbers look like?
I unfortunately don't have figures with me, but definitely backlog is still a problem and is being addressed and is different. I mean, the way they're addressing it is different from province to province in terms of availability of resources. Because part of the issues, we lost a lot of expertise to private sector at some point. And another issue is this of COVID-19, which actually deterred everything that must have been done on time according to plan. So that is part of the issues that are now currently at play. But, I mean, efforts are being put in place to ensure that we curb as much as possible to ensure that patients are accessing treatments and we actually reaching the survivorship that we would want to reach at the end of the day.
What are we doing to catch up? What's the plan? I mean, we've mentioned COVID-19. We know that we've lost tons of specialists to the private healthcare sector. So what are we doing for the hundreds and thousands of people that are sitting, have a diagnosis of cancer, whether it's an early stage or a late stage, and are looking to get to treatment? How are we assisting those people?
The way that we are assisting those people is to, obviously, those people are being attended to at certain facilities, and then they are being fast-tracked as much as possible to access treatment on time, because there's no point of having patients diagnosed on time and they do not access treatment on time, because we know for a fact that cancer is growing every day. So that is something that is being done. And with the assistance of the academia as well as the provinces that are actually fit to can assist, like your Gauteng, they are really assisting a great deal in different provinces where they are deploying their own people to assist with surgeries and all that in different provinces as per memorandum of understanding, of course.
So let's speak about the idea of accessing these oncology services, so these cancer care services. Is it a free service? I mean, we all know cancer is an expensive disease to have. Whether it is the surgeries that they need to plan for, whether it is the chemotherapy and the multiple cycles of chemotherapy that you must get. Is it an expensive disease to have? And if you're diagnosed with cancer in South Africa, who pays for it?
Actually, cancer is quite expensive to manage, like you have alluded to. And definitely cancer is not a one-man show kind of approach in managing. You really need a multidisciplinary team to manage that the patient that is in front of you. So it's an issue of budgets. And I mean, obviously, with the cut of budget, is going to even aggravate the situation that we are currently in. So I think negotiations are up with National Treasury to ensure that there is a proper budgetary system that will actually assist with the cancer patient. Because, I mean, taking into consideration the SONA speech for 2019 from the presidency, where he has put cancer at the top of the agenda for South Africa to improve survivorship. I mean, that kind of conversation is actually assisting in keeping everything in the right direction to ensure that patients are accessing treatment on time and improve survivorship.
So if I'm unemployed, for instance, and I've gotten a cancer diagnosis and I go to the hospital and I'm supposed to get chemo, do I pay out of my own pocket for that chemo? Is it subsidized? Do I pay anything? Is it free?
Basically, in South Africa, they are not actually paying, but it depends on the scale, because obviously every patient must be scaled in terms of affordability. And then part of them are actually do pay something for their services that they are receiving. But we know for a fact that when you look at the finances from screening to diagnosis and treatment, I mean, per patient, I'll just give an example of a breast cancer patient whereby one patient would really require 1.2 million for treatment from screening to that. And you'd think of, I mean, the whole lot of patients that are actually now getting cancer and as to whether the government will be able to catch up with that. But with the assistance of the non-government organizations and the other groups that are interested in cancer care, I mean, that can be realized.
Well, thank you so much for coming and highlighting and enlightening us on what the department is doing in terms of the National Department of Health with respect to assisting people that have cancer and all the things that they're doing in order to address all the backlogs that currently exist and the new nodes of cancer treatment that will be popping up in different provinces to assist with this heavy burden of disease, but also trying to get treatment out as much as they possibly can. That was Tonya Khaye assisting us with all that information. Thank you to all the guests that participated in today's show, and thank you for watching Vital Signs today. We hope that our show has really put a little something in your head that you walk away with, and that when you have those conversations throughout the week, you're able to add and assist someone in some way, shape, or form. I'm Dr. Musa Winkosi Ntomeni. We'll see you again next time. This was Vital Signs.